Hello and welcome to this learning module. Today we will discuss the assessment and management of injuries to the abdomen and genitourinary system. This video is intended to supplement any readings or coursework assigned by your instructor. The objectives for this learning module are: number 1, review the pertinent anatomy of the abdomen and genitourinary system. Number 2, describe the assessment and management of abdominal injuries. And number 3, list the assessment and management of injury to the kidneys, bladder, and genitalia. First, let's review the anatomy of the abdomen. This image illustrates the 4 abdominal quadrants and reminds us which organs sit in each quadrant. The right upper quadrant contains the larger lobe of the liver, the gallbladder, a portion of the pancreas, and part of the small and large intestines. Organs in the left upper quadrant include a small lobe of the liver, the spleen, the stomach, the majority of the pancreas, and large and small intestines. The right lower quadrant contains a portion of the large and small intestines as well as the appendix. Organs in the left lower quadrant include the large and small intestines. The lower quadrants also contain the ureters, and in females contain the ovaries and fallopian tubes. The visceral peritoneum covers and supports the organs, while the parietal peritoneum lines the inside walls of the abdominal cavity. The peritoneal lining has nerves that will produce severe and constant pain when irritated by substances such as blood or urine leaking into the abdominal cavity. The kidneys are located in the retroperitoneal region of the posterior aspect of the abdominal cavity. Abdominal organs are classified as either solid or hollow. Solid organs are made of solid masses of tissue and include the liver, spleen, pancreas, and kidneys. Hollow organs are structures that materials pass through. For example, food passes through the stomach and large and small intestines, while urine flows through the urinary bladder and ureters. The urinary system consists of the kidneys, which are solid organs that filter waste and excess water from the blood. The kidneys sit in the retroperitoneal area just below the rib cage. The ureters transport urine from the kidneys to the urinary bladder, which is a hollow organ located on the pelvic floor. During urination, also called micturition, the urine leaves the bladder and exits the body via the urethra. Trauma affects hollow organs differently than solid organs. Hollow organs, including the stomach, intestines, gallbladder, and urinary bladder, have contents that can result in peritonitis when leaked into the abdominal cavity. You recall from medical emergencies that peritonitis is one of the primary causes of acute abdomen. Solid organs are very vascular and can lead to life-threatening internal bleeding when injured. The liver, spleen, and kidneys are all very vascular solid organs that can bleed profusely if lacerated or fractured. All patient assessment begins with the completion of a scene size-up and then a primary assessment to identify life threats, including problems with airway, breathing, and circulation. With abdominal injuries, blunt trauma is likely to cause internal bleeding, while penetrating trauma can lead to complications such as evisceration of abdominal organs that protrude through the open wound. When evaluating the abdomen, EMTs must remember to inspect and palpate for injuries. While providing the patient's privacy and dignity, the EMT should inspect the abdomen for signs of redness and bruising. These may be indications of underlying blunt trauma. In the image on this slide, we see a provider palpating the patient's abdominal quadrants to identify areas of tenderness, rigidity, or distension. Advanced providers should also auscultate the abdomen for bowel sounds and may also percuss the abdomen to help identify areas of suspected injury. An open abdominal injury, like the projectile injury seen on the left, happens when the peritoneal cavity has been opened to the outside from a penetrating injury. Conversely, a closed abdominal injury occurs without breaking the skin and is commonly seen after blunt trauma or a deceleration injury. In the image on the right, we see a closed abdominal injury caused by a seatbelt during a vehicular deceleration incident or crash. Treatment of open abdominal injuries includes maintenance of ABCs, controlling external bleeding, determining the need for spinal motion restriction, treating for shock, and placing the patient in a position of comfort for transport. If there is an impaled object, care must be taken to stabilize the object for transport to the trauma center. A high index of suspicion for internal bleeding should be considered with any suspected closed abdominal injuries. The possibility of internal bleeding may not be ruled out by the absence of redness or bruising to the abdomen and must be considered when the mechanism of injury is suspect for abdominal trauma. Treatment includes maintaining ABCs, treating for shock, and placing the patient in a position of comfort. When transporting a patient with obvious or suspected abdominal trauma who does not require spinal motion restriction, a position of comfort is one that reduces tension on the abdominal wall. This might include elevating the victim's knees with a pillow or blanket or placing them in the fetal position. All patients with suspected trauma should be treated for shock, including administration of supplemental oxygen, keeping the patient warm, and proper positioning. An open abdominal wound can allow abdominal organs to protrude through the wound. This type of injury, illustrated in the image here, is called an abdominal evisceration. Normally, providers will see a section of intestines protruding through an open abdominal wound, but other organs may be visible as well. Never attempt to push the organs back into the abdominal cavity. Management of a patient with an abdominal evisceration includes placing the patient supine and treating them for shock. To dress the evisceration, we take a multi-trauma dressing and moisten it with sterile saline. This dressing should completely cover the wound on all sides. Then we take a piece of plastic and secure that over the moistened dressing. This will help to maintain body heat as well as keep the dressing moist during transport so it doesn't damage the underlying organs. Some abdominal dressings come packaged with plastic sheeting that can be used to cover the dressing when managing an evisceration. Trauma to the kidney can occur from a forceful blow such as sports injuries or can be caused by penetrating trauma. Signs and symptoms include shock, blood in the urine, a penetrating wound in the flank or upper abdominal region, lower rib cage fractures, and a hematoma in the flank region. Additionally, abrasions and lacerations in the flank area may also indicate trauma to the kidney. Treatment includes managing shock and prompt transport with ALS to a trauma center. Monitor vital signs closely because internal bleeding may cause an abrupt change in the patient's vitals indicating deterioration. Rupture of the urinary bladder caused by penetrating or blunt trauma can cause urine to spill into the surrounding tissues as well as the abdominal cavity. While urine in the bladder is sterile, it can still cause significant infection and peritonitis. In male patients, a sudden deceleration injury can shear the bladder from the urethra. Females in the second and third trimester of pregnancy are also at an increased risk for bladder rupture secondary to blunt trauma. The internal female genitalia are generally well protected, but can be subject to the same types of injury from blunt or penetrating abdominal trauma. Determining the possibility of pregnancy is an important part of the patient assessment when caring for a female patient with a traumatic injury. A gravid or pregnant uterus enlarges the uterus and causes it to rise out of the protected region of the pelvis. The gravid uterus also has a rich blood supply, so trauma can lead to internal bleeding and shock. Trauma to the female external genitalia can be extremely painful due to the rich nerve supply in this area of the body. Management of female external genitalia trauma includes covering all open wounds with dressings that have been moistened with sterile saline. Gentle pressure should be applied to control any bleeding. A sterile absorbent sanitary pad may be applied as well. At no time should anything be inserted into the vagina, as this may lead to further damage. If tolerated, a cold pack may provide some comfort and will help to control bleeding by constricting blood vessels. Any penetrating trauma or foreign bodies need to be stabilized prior to transport. These types of injuries should be transported to the trauma center for evaluation. Due to the rich supply of nerves, trauma to the male external genitalia is also painful. Despite what the patient may believe, these types of injuries are rarely life-threatening. Injuries to the scrotum can also be very uncomfortable for the patient. Direct blows to the scrotum can result in rupture of a testicle or accumulation of blood around the testes. If tolerated, application of a cold pack to male genital injuries will help control bleeding as well as alleviate some of the associated discomfort. In the event of a degloving injury to the male genitalia, the avulsed tissue should be retrieved and transported wrapped in a saline moistened sterile dressing. The injury site should also be wrapped with a moist dressing. When caring for a penile amputation injury, bleeding control with a sterile dressing and direct pressure becomes our priority. The amputated part should be retrieved, wrapped in a saline moistened dressing, placed in a plastic bag, kept cool, not packed in or on ice, but kept cool, and transported with the patient to a facility capable of surgical reattachment. If your patient has the misfortune of getting their genitalia stuck in a zipper, you can try unzipping it if only one or two teeth are involved. If a longer segment is involved, then cutting the zipper away from the pants may make the patient more comfortable for transport. Be sure to explain to the patient what you are doing and use caution not to cut any tissue. Lastly, never move or manipulate foreign objects in the penis. Do your best to immobilize the object for safe transport to a surgical care facility. While more common in women, sexual assault can happen to men and children. If a sexual assault is suspected, try not to examine the genitalia to protect any evidence that may have been left by the assailant. If the victim is bleeding, a sterile dressing should be applied. Work with your local law enforcement to protect evidence such as clothing that may have been removed by the victim after the incident. Any evidence should be placed in a paper bag and handed to law enforcement or brought to the hospital and given to the sexual assault nurse examiner based upon your local protocols. Do not allow the victim to wash, bathe, shower, urinate, defecate, or douche until after they have been examined at the emergency department. If oral penetration occurred, do not allow the patient to eat, drink, brush their teeth, or use mouthwash until being seen at the ED. Placing a sterile burn sheet on the stretcher and wrapping the patient in it will also help to prevent loss of evidence. Treating physical wounds, providing compassionate care, and preventing loss of potential evidence are key to treating a patient who has been sexually assaulted. This brings us to the end of our presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you struggled with. Thank you for watching this learning module.